Welcome to chat number 2 on glaucoma. This is investigating glaucoma, again for optometrists. Before I start this section, I want to make this following statement. I think we should question things. I plagiarize this from the Buddha. Question everything, find your own truth. And I will be posing some questions about what we do. And I think we all should. You don't have to agree with them. But I do think it's important that we don't just follow mantras that are given to us. We've got to consider what we're actually doing. So the lecture today is a review of traditional investigation techniques for glaucoma, the usual triumvirate. And I also very lightly introduce the newer investigative techniques that we're all becoming relatively comfortable with these days. But really I want to consider an anatomical sieve to systematically and thoroughly investigate glaucoma. I think it's too easy to just dive for pressures, dive for optic nerve, dive for fields, then refer. And we mentioned the procedures for gonioscopy examination of the anterior chamber and its grading will be covered as well. So in the 20th century, we had our three. We had IOP, we had our optic nerve assessment, usually with an ophthalmoscope, and we had some sort of field test, and earlier on very rudimentary, I would say. So the IOP is a risk factor. The optic nerve assessment is important from a clinician's point of view because we're looking at the structural damage done. Fields are really important from a patient's point of view actually because it's the functional impact. Now into the 21st century, obviously we've improved those three. We now incorporate pachymetry into our IOP measurement, and this is actually really important. And I'm going to suggest, and I hope I'm going to prove to you, that CCT, corneal thickness measurements, are really a surrogate measure of corneal biomechanics, because we can't measure true corneal biomechanics without excising the cornea, so CCT becomes pretty much our best alternative. And now, of course, we've got stereoscopic Volk examinations, we've got CLOs, we've got OCTs, and certainly it makes looking at the optic nerve just so much easier. I don't know how people use ophthalmoscopes. And for fields now, we've also got OCTs and SLOs and so on that can plot somewhat objectively what we expect to find with the fields. Now that's still maintains, that's the three, isn't it? But as independent prescribing optometrists, I want to suggest to you that if we're investigating glaucoma, we must not stick to that. We've got to be thorough and we've got to have a systematic technique for investigating an extremely complex disease process. You don't want to just do fields, do pressures, look at the optic nerve and refer. So, you know, we need a thorough case history, we need tonometry, we need pachymetry, we need some form of angle assessment, and then looking at the anterior chamber for secondary glaucomas. Then finally we go to the optic nerve, and then finally we do fields. And fields obviously have to be the final thing in my opinion, because the choice of technique that you're going to do for fields has to reflect all the other stuff. It should never be a pre-test, obviously. But we have to stop thinking IOP discs fields, in my opinion. So tonometry. What on earth can you say about tonometry? This section's quite long actually because I did my doctorate on this. It was called Tonometry, a Study in Biomechanical Modeling. And I have what I consider quite important, valid points about some of the things that are being presented to us these days. But certainly we can all agree that IOP measurements have long been recognized as having limited diagnostic value in isolation. And I think that's an important point, in isolation. No good combination of sensitivity and specificity at any cutoff points ever been demonstrated. And of course, further that, what about the accuracy and repeatability? If it's very variable, if its accuracy, well, not accuracy, if its repeatability is variable, then you can't be sure where in that range of variability you've taken the measurement anyway. However, IOP is still a key part of the diagnostic process. We have to have a baseline. Since treatment is aimed at reducing IOP, we need to have some baseline on which to say, yes, we've achieved a reduction, or we haven't. and we may choose it depending on the disease severity at first diagnosis. But we know from that Medscape thing that, the spread of field loss and IOP is huge. There's that little blue area ranging from something like, I don't know, about 15 mils up to obviously over 30, which shows glaucomatous field loss. But it's in amongst that olive area where there's no glaucoma at all. So we're trying to pick that tiny little blue area out of that huge area of noise of normal patients. So tonometry is pretty dodgy. So I want to introduce these concepts: validity, repeatability, and utility. Validity is accuracy. How accurate is the machine in measuring the real value, the intracameral IOP? Repeatability, how consistent are those repeat measures? And then this concept of utility asks the question, is the information actually of help? Now, does the number matter? No, it absolutely does not. Mills says, an absolute measure of IOP is not usually important, rather a comparison to a standard baseline. And this was a concept even introduced by Glaucoma in 1885. If a gap measure could be relied upon to represent a standardized measure designated IOP, that we designate IOP, it doesn't matter if it's 2 or 3 mils or 2 or 3 mils below or above, so long as it's repeatable and reproducible, then nothing else actually is required. And indeed, that's one of the greatest arguments for maintaining GATT as a reference. These authors say, regardless of technological improvements, since virtually all literature and clinical trials were based on GATT, this is going on 70 toward 80 years, redefining the standard would necessitate redefining statistical norms and targets, which would be an absolute nightmare. Does the number, repeatability matter? Absolutely. If a tonometer can't agree with itself, it's not likely to agree with anything else. And regardless of how accurate an innovative new machine may be, it will not show agreement with the reference if the reference machine shows poor repeatability. So the number is really important, or the repeatability of that number. And then utility, is it important? Brandt says, IOP collection is flawed. Clinicians assess a complex and highly variable pathological process based on IOP snapshots. So a 10-second snapshot of IOP in a clinic room during clinic times every 6 months, say. Is that important? How does that help us? Well, there's new technology out there. Triggerfish, and there's is a contact lens with a sensor in it, and it records 24-hour variation that is due to IOP. Now, these two authors, this came from Switzerland. There's actually there's a Professor Elsheik at Liverpool Uni who's coming up with more as well. But these two authors say the future of glaucoma diagnosis and management will require an entire paradigm shift. They suggest, how are we going to ever assimilate the ensuing data avalanche, and how do we cope with the educational challenges that this will pose clinicians? This is a serious question. This technology is out there, but how on earth are we going to assimilate it when we're so used to 80 years of single readings? So is the Goldman the gold standard? I mean, first of all, I ask you, has anyone actually ever looked inside one? This is the 21st century. And if you look inside one of those things, it's pretty primitive. And despite expert opinions saying it's still the best, and meta-analysis coming up with, because there's no contra evidence, but there are some very, very famous people out there who do not think it's the best thing. Whitaker and Steen back in 1993. The premise of tonometry is the so-called Imbert-Fick law, not a law at all, but an explanation of tonometry where none of the assumptions are true. The Imbert-Fick construct was not the foundation on which tonometry was developed, but was an attempt to explain the technique post-construction. Now, I'm not sure I totally agree with that second section, having read all of the papers right back for the very first ones, Imbert and Fick. However, it does suggest that there's questions out there. It's not all clear cut. Back in 1960, after Goldman had just come out, GATT had just come out, this so-called law was not introduced by an expert physicist or mathematician. I think that's important to think, but by an ophthalmologist who invented a tonometer and looked for a logical foundation to support the instrument. In my opinion, these theoretical speculations are quite erroneous. And again, I agree with that actually. But this contemporary chap from the University of Dresden, I suspect almost no one critically read the papers of Goldman and Schmidt, which contained the limitations of the method outlined by the authors. Today, the basic biophysical and statistical details are forgotten, and applanation tonometry is used with the same assurance as a ruler to measure length. Wow. And then it gets really nasty now. Why are we worshipping applanation tonometry like a golden calf? The reason is a historical one. Hans Goldman was very famous. And it's true, if you're very famous, your kudos is high, you get things going quickly. And Brandt, in 2004, our ability to accurately measure IOP far weaker than imagined. We rely on a flawed measure on which to base clinical decisions. So all these things are very important. And indeed, Goldman and Schmidt themselves, in their first paper, well, second paper in 57, they admit the use of coarse methods to model the eye and suggest their conclusions may represent first approximations. So that's their comment 60 years ago. But it turned out to be not the first approximation. It turned out to be the only approximation. So when we're comparing instruments, we used to always use correlation coefficients, but they're not useful for comparing tonometers. Readings can be well correlated, but still not show any agreement. So the only correlation slope that also gives agreement is if it's at 45 degrees and is a straight line. Then you know that when one machine measures 15 millimeters of mercury, the other machine measures 15 millimeters of mercury. But that's a rare situation. That line correlates, but it certainly doesn't agree, except at one point. And indeed, you can have negative correlation. So they're all correlations, and they'll have very good correlation coefficients. You know, they'll be 0.92, 0.98, if they're a perfect straight line, which you wouldn't get anyway. But but that doesn't mean they agree. So the correlation coefficient's out the door. And in 1986, that's when Bland and Altman came up with this revolutionary thing. And their original paper was printed in the Lancet. So it was a pretty important paper. But what they said was, their premise is, and this is important because this technique, I think, gets misinterpreted at times. So what they're saying is the reason they came up with this is they said neither instrument can be assumed without error. The only anchor and the best estimate of true reading is the mean of the two measures. It would be a mistake to plot the difference against either value separately, because the difference is related to both. So relating, it means that if you assume one machine's perfect, then all the error is attributable falsely to the other instrument. And this is obviously a statistical fallacy. So they came up with this nifty way of doing it, but their goal, well, I'll come on the next slide. So Bland and Altman specify the rationale, the reason for coming up with this statistical technique. And as they say, many medical assessments for practical necessity rely on indirect techniques to estimate the real measure. The true value remains unknown. The true value was unknown before you compared the two instruments. The true value is unknown after you compare the two instruments. So the goal is a much more modest one, although one could argue much more important, than simply trying to compare to a gold standard. It simply reflects the pragmatic assessment of whether one instrument can replace another without compromising clinical management. And that's the important point. And it's not the same as comparing to a gold standard. Comparing to a gold standard would be calibration. So if two indirect instruments are compared, neither can be assumed to be the best. Both exhibit variability, and it is highly unlikely the methods will agree. The outcome is a clinical need or expectation, not a statistical one. So the question is the difference between the two methods likely to change clinical management? And the magnitude of acceptable variation is a matter of clinical judgment, and the authors do stress this, that should ideally be defined in advance. So you don't do the statistical technique and find out your 95% confidence levels of agreement and then say, yes, this proves this, that, or the other, or it proves that we've got to keep using GAT or whatever it might be. That's not the point. You've got to say up front what you're prepared to accept as a clinician, not as a statistician or a paper writer, but as a clinician. What are you prepared to accept in the assumption that it will not change your clinical management? Now, if you do come up with a revolutionary new machine, then you need to really compare it to a much more robust, true gold standard. So if you just want to introduce a new machine and get it into the market quickly, then yes, compare to the reference standard, which currently is Goldman. But if you come up with a new machine that utterly questions the GAT premise, then you don't want to be comparing it to GAT, you want to be comparing it to manometry. And that's a calibration process, not an agreement process. So let's assume that we're non-biased assessors. We come from a different background, perhaps biomechanics. We're given these two tonometers. We have no clue which is the better one. We just want to know that can one replace the other. So we have to sit down and decide, first of all, what would be our acceptable clinical difference before we set up the experiment. So I thought to myself, we take the 2009 paradigm or algorithm for prophylactic treatment of ocular hypertension. Now I know they've changed the baselines now from 21, but you know. So if we've got a patient with ocular hypertension and a CCT of 600 and a recorded IOP of 31 millimeters of mercury, the algorithm there states that no treatment is required. But if the same patient with an IOP of 33 millimeters would suggest that we prophylactically treat. So we could argue quite soundly, I think, that a variation of 2 millimeters of mercury could alter management. So is that a realistic goal? And what is the variability in the pachymetry measures as well, incidentally? You know, it's not just the IOP, but how accurate is the pachymetry? That's a whole other area. So the Bland and Altman technique actually can give you two things. It gives you correlation of repeatability, which is where we take one instrument and we compare it to itself. So repeat measures, whether it's in the same day or over a period of time, whatever, we repeat the measures to see how well it agrees with itself. And technically you need to do that before you do the next bit, which is limits of agreement, where you compare one machine to another. Because if you don't know the variability and the repeatability of each machine, it's very difficult to interpret the limits of agreement between the two machines. So let's compare, for this exercise, GAT with a particular NCT, the ocular response analyzer. So when we repeat GAT, we get a spread. We get a bias of minus 0.11. That's kind of insignificant anyway, isn't it? It agrees with itself. But what's important is the correlation of repeatability is pretty much plus or minus 5 millimeters of mercury. And the repeatability, the correlation of repeatability of the aura is, quite frankly, equally bad. It's again pretty much plus or minus 5. You'd kind of think perhaps because it was an objective machine it might be better, but it's still pretty wild. So you've got a lot of variability within the machines themselves before you go on and compare one machine to another. So when you do the comparison one to the other, which again is incorporating the variability of both machines, they do actually agree. The bias is only 0.3 millimeters of mercury, so they pretty much agree. But the range is again plus or minus 5 millimeters of mercury. So when we do the Wilcoxon signed rank test and the null hypothesis, it says we do accept the null hypothesis. Those two machines do agree with each other, and they're only 0.3 millimeters away in the bias. But it's the range, the variability in the system, that's really the problem. And that's a really difficult one to try to control. And ISO 8612 for tonometers does make this point, actually. They actually, first of all, they say in there, incidentally, the trouble with ISO 8612 is that you've got to buy it. You can't just look it up. And so a lot of researchers don't bother looking it up. They just reference other references. And they say ISO 8612 says you must compare to GAT. And it doesn't actually say that. It says the true intraocular pressure is seldom directly measured since it would require invasion of the eye. Since a true IRP cannot be clinically measured, alternative methods are specified for determining a reference. So again, this is simply saying, can one machine replace another machine? And they use the same sort of thing, but they are quite specific. They say to pass this, you have to have 120 eyes. You have to measure 40 between 7 and 16 millimeters mercury, 40 between 16 and 23, and 40 above 23. So all these other papers that come out ad hoc later, they're not following any ISO 8612 protocols. And if you're going to compare two machines, one could argue you should at least use an acceptable protocol. So all these other papers, you could question their validity anyway, because they're all using different strategies, different techniques, and they're claiming certain things. At least ISO 8612 say you have to do this, but look at it. The tolerance is plus or minus 5. So they'll allow a tolerance of plus or minus 5 millimeters of mercury for an instrument to be accepted. And that's okay, because we know you couldn't expect better because the variability in the machines is that bad. But every machine that hits the marketplace, it has to be assumed it has passed this test or it wouldn't be allowed to be marketed. So why we continue to keep comparing machines to machines when we know they've gone through quite a stringent technique already? And if you are going to question it, if you're going to question NICE itself, then fine. But don't just do ad hoc ones. You've got to actually physically do it the way they do it and see if you come up with the same result. So this is the sort of information that's presented in papers under very much idealized situations. And well, they actually say that under ideal circumstances of measuring the precision figures for GAT, they say that intra-observer variability, that's two readings by the same observer, will be within 2.5 millimeters of mercury with 95% confidence, which doesn't seem too bad. Inter-observer variability could be 4 millimeters of mercury. There are two papers that have come up with that. Thorburn and Castor reported 5 millimeters, plus or minus 5 millimeters. And as I say there, in clinical practice, they're not ideal conditions, and these figures may be considerably higher. And that's actually true. You've got to think that. These papers are done where one person is, well, let's bring this up. We know for a start that the correlation of repeatability of GAT itself is plus or minus 5 millimeters. So that's the measurements we've come up with. So it correlates more with the sort of Thorburn and Cass type stuff. But also this one here, does this reflect accuracy or repeatability, actually I should say, sorry, or is it simply the clinician's repeatability of their own technique, because they're comparing themselves to themselves? And even if they're wrong, even if they're making the wrong reading, if they repeat their own technique, they'll probably show quite good repeatability. So even the figure has to be critically appraised before you think about how you're going to interpret it. We already all know that there's a huge number of things that do cause variability in all tonometry measurements. Some are objective, some are subjective. Instrument techniques, physiological variability, circadian rhythms induce spikes. Whitaker and Steen suggest a CCT can induce a 9.9 millimeter of mercury span in GAT for the same intracameral IOP. There's mechanical friction. One of the great things about GAT was the fact that it reduced machine variables from 20 in the SHIOTS down to 3. So that was a great thing. But then what about solid state stuff now? Surely we can reduce that even further. Obviously IOP is more variable in glaucomatous patients anyway. Then there's biomechanical variability, rigidity, stiffness, shape, which I'll come on to. Let's stick to shape for a minute. Artificially thin corneas with LASIK. But shape, you're ablating the cornea. And the clue's in the name. It's applanation tonometry. That is to say, we're making a plane surface. So if you've already ablated a cornea, the flattened shape must change the reading. Theoretically, if you had a completely plane surface, GAT would record a reading without actually applying any force at all. Certainly tears with GAT are a huge area of error. There's CCT, thick and thin, scarred, soft, distorted. And I'll come on to that ad nauseum later. And then there's certainly inter and intra-observer variability. So there's a whole range of things that can cause this variability. And, the ideal tonometer has to try to control or eliminate all of those things. So the question people pose always is, are all NCTs bad? Or they might not phrase it like that. They might say, all NCTs are bad. And certainly NCTs have a poor reputation with ophthalmologists dealing with false positive referrals. And it must be frustrating. But is it the fault of the NCT? Or is it perhaps the fault of how some optometrists responded to the 2009 NICE guidelines? If you look on the left-hand side here, this is a thing I did. And again, I stress the point, I wasn't making any assumptions as to what tonometer was better. I was simply comparing them all to each other, rather than just saying, GAT to ORA or ORA to GAT or whatever it might be. I compared them all to each other and saw how much they biased and so on. And now the NCT, the only one we did there, the ORA, actually agrees with GAT. There was no statistical difference between the readings of ORA and the readings of GAT. So they agree. And this was a lot of patients. This was, 150 odd patients or something that we compared with. So they agree. So why, and okay, that's one bit of evidence. You could get another one that doesn't. So, but why the bad rep, really? I mean, could it be the fact that did all optometrists repeat the NCT? Or simply back in 2009 anyway, state NICE said pressures 21, refer. Did they, we always repeat GAT. We're always told now to repeat GAT. So did these optometrists repeat NCT before referral? Is the variability simply within the repeatability of GAT and NCT? Did the optometrists read it within a zone of variability, and by the time it hit the ophthalmology department, they recorded in a different zone of the variability of GAT and NCT? And certainly was NCT used as a single referral criteria in the absence of other signs? And as we'll see in the next lecture, NICE specifically say you must never refer based on one NCT reading. Well, they wouldn't have put that in if some optometrists weren't exactly doing that. And of course, who makes the final decision on correctness? Well, it's the ophthalmology department. So it could be a sample bias. And in fact, Henson and Harper wrote a cracking paper back in 1998 on this, do non-contact tonometers read high? And they basically gave very good evidence that it's a biased sampling process that could be questioned. So, here we look at the general variability of GAT versus ORA, and although they agree, there's certainly a lot of variability in there. And you think, well, did the optometry department, when they referred, measure it in one part of that variability zone, while the ophthalmology department measured in another part? You just don't know. And then the other point, NCTs are more susceptible to the effects of CCT. And are they? They're GAT mimics. Let's have a look at it. So this is the question I'm putting. So what the hell is CCT, modulus of elasticity, and hysteresis all about? Is it a help or is it a hindrance? So these two, I don't know if you know these things, the term hysteresis has come into our vocabulary since the aura was developed. And it's bandied around. So this particular author says, it's recognized a number of corneal parameters can affect the accurate measurement of IOP and also may be independent risk factors for glaucoma progression. So how thick is it? Central corneal thickness, CCT. Thicker corneas measure artificially high, thinner artificially low. How stretchy is it? And they're saying that's the modulus of elasticity. And how springy is it? And that's corneal hysteresis. Now they also say, look, I'll come back to those things in a minute. They also say CCT may be an independent risk factor. So yes, because the cornea is attached to the sclera, which is attached to the lamina cribosa, and since we know that the lamina cribosa is the site of damage, then yeah, for sure, a thinner CCT could actually be a direct link, mechanical link to the lamina cribosa. So it could be an independent factor. But that's not part of today's lecture. Today's about the accuracy of GAT in this case. So let's have a look at this. How stretchy is it? Modulus of elasticity in biomechanical terms is a measure of a material's stiffness, not stretchiness. And this is again vocabulary. You've got to use the right vocabulary. It's too easy to shove this stuff in and it sounds good. Corneal hysteresis, how springy is it? Well, hysteresis technically is simply one part of a tissue's viscoelasticity. And because this is the sort of stuff that is bandied around, I feel it's important to take time to explain how this really works. It's convoluted, it's long, I'm sorry. So most tonometers have to contend with biomechanical resistance of the cornea. So they've got to push that cornea in so far. Now I say most because there is one is based on a theoretical principle that's quite robust actually. But what are the corneal biomechanical profiles that we have to consider? Whitford, they consider corneal biomechanics as an expression of geometry. So we think of biomechanics as just a cellular type thing, but it's thickness and topography, so and material stiffness. And material stiffness is contingent on the corneal microstructure. So while we can measure topography and CCT in vivo, corneal microstructure we can't do. We would have to excise the cornea to measure the stiffness. So that's why CCT is almost by default, well, it is the only thing that we can really measure. Well, theoretically. So as we already said, we can't measure corneal tissue stiffness without excising strips and stressing. So if we were really to look at the biomechanics of the cornea, we'd have to be looking at that, which we can't. So the primary measure of microstructure is this thing called Young's modulus, which is also called modulus of elasticity. They're the same thing. And the elastic modulus is the ratio of pressure applied to the change in length induced. So it's a measure of the intrinsic stiffness of a material. And that is not synonymous with rigidity. And this is where a lot of the literature gets way confused, because they're being written by optometrists and ophthalmologists, not by people who understand biomechanics particularly well. And they just, and you know, if you say something's rigid or stiff, it sounds like the same sort of thing. Well, they're not. Biomechanically, they're not. So elasticity reflects a material's capacity to sustain stress without permanent deformation. And when the stress is removed, the material will return to its habitual dimensions. So the loading-unloading curve is a straight line. And the mechanical stress energy is stored reversibly, allowing the material to revert to its original dimensions on removal of the stress, without loss of any energy as heat. So that's the modulus of elasticity, or Young's modulus. So CCT should really be considered simply a surrogate measure of corneal biomechanics, but it's certainly not perfect. So while CCT is very important because it is the only in vivo measurable reflection of corneal biomechanics, there is something else coming up that people claim is another measure, which I dispute. But CCT must not be assumed an absolute. No correction algorithm has been validated, says Brandt, and proposed corrections range from 2 to 7 millimeters of mercury per 100 microns of corneal thickness. And Brandt even showed that the assumption of linear correlations could lead to a negative value of IOP in specific cases when you do the correction. So, and this was the whole drive in the early 21st century, was to come up with this nice algorithm where we could correct GAT readings for the variability that CCT created. But it turned out that it didn't really work. And Liu and Roberts have a simple metaphor for this. They say, you know, you might have a steel rod and a wooden rod, and they might be both the same thickness, but the wood rod will be more easily deformed than the steel rod. So it's the microstructure of the actual thing that we're measuring that really plays a role, not the actual thickness, but the thickness reflects it to some extent. So for instance, if a cornea is mega thick but edematous, it will not be as stiff, i.e. it would have a lower Young's modulus. But if a cornea is very, very thin but scarred, it could actually be stiffer. So again, the microstructure is important. Now, another couple of points. The modulus of rigidity is shear modulus. So if you use the term shear modulus, it's more descriptive than saying modulus of rigidity, but they're the same thing. And this represents the elastic modulus in shear. So it is a different thing to Young's or elastic modulus. So as such, the forces are applied in the material in opposite directions in different planes of material. And this does happen with GAT and all GAT mimics. They are causing shear forces as they bend the cornea around the zone of bend. And that also introduces these things called boundary conditions, which are zones of stress at interfaces. And they're extremely important with GAT and GAT mimics, specifically GAT and GAT mimics. So during applanation, the pressure profile in the peripheral cornea, notwithstanding the additional external loads, will be actually different to the profile under the tonometer probe. And indeed, the zone of flexure between those two zones is a boundary condition. And there's certain forces going on in there that no GAT models ever really considered. And then we introduce this thing called hysteresis. So viscoelasticity, which we all know about, comprises three things actually: creep, relaxation, and hysteresis. Now, hysteresis describes the different stress-strain response during cyclical loading and unloading of a biological tissue. Okay, the constitutive equations are different for each phase. And loading and unloading, unlike the elastic material that you see there, are not straight lines. So Young and Bodanis, they describe it in a mechanical terms. Hysteresis is the result of dissipation of energy as heat during a stress cycle. So it's not quite the same. But it still has to do with the microstructure. So this is where this Aura machine came in. These two, Luce and Taylor, found, Luce in particular, I think, the inward, so you're doing applanation with an air puff tonometer. So you're increasing the air pressure to applanate the cornea. And the inward traditional measure is taken as the air puff increases and the convex cornea is flattened to a plane surface. And that's P1. Then the aura shuts off, this is all tonometers, all NCTs, shuts off after P1 is reached, but there is a certain level of inertia in the system and the pressure continues to increase before reaching a peak. So at this point, the cornea is concave. Now the pressure then, or at least the cornea, then starts decreasing again as it returns to its habitual shape. So the forces within the cornea and the IOP, then obviously when the pressure is finally released and it's shut off, the cornea then starts to revert and it goes back to its, through a plane surface back to a convex surface. And when it hits its second plane point, again, it's no different to the machine. It knows it's a plane surface, so the polarized light gets caught again, and it takes a second reading. But the second reading doesn't read a pressure that's the same as the first reading. And the authors dubbed this lag between P1 and P2 as corneal hysteresis, suggesting it is created by the viscous dampening of the cornea and qualifies biomechanical properties of the cornea. So they have taken an observation of a machine and created a biomechanical, what I would call a quasi-biomechanical concept to be associated with it. And then they're putting importance on that reading as a measure of corneal biomechanics. Something which I have to say I question. So Dupps back into that reports Luce as defining corneal hysteresis more conservatively. So they had this great claim about it really is a measure of corneal biomechanics. But originally, Luce defined it as conservative as the output of the aura under specific measurement conditions imposed by the aura. Because if you think about it, the cornea has gone through its plane surface where the first measure is taken, then it proceeds into a concave configuration before when the pressure plume is cut off, and then all the pressures in the eye and the cornea start forcing it back into a habitual shape where it simply takes another measure. Making the assumption that is a reflection just of corneal hysteresis is, in my opinion, a little bit of a leap. But certainly the cautionary interpretation of the new metric Luce and Taylor suggest reflects the limited understanding. This was back when they first came up with it, though, back in 2006. The limited understanding of what the waveforms actually represent. So they didn't understand it, they observed it and then decided that they could interpret in a certain way. And I do think the interpretation is up to a certain level of debate. These other authors modelling the return applanation conclude the corneal response is influenced not only by corneal biomechanics but by the IOP pushing backwards, the CCT, the curvature, and it's bound to be, in my opinion. So the idea, though, I've had emails with these characters. The idea was to adjust gap equivalent reading. So they had an Aura IOPG, which was their equivalent reading of a GAT reading, as a standard NCT would be. But they wanted to compensate it for corneal biomechanics, hence the IOPCC. So they did an algorithm where they adjusted the reading based on this second reading in a proprietary way. But since there's but when we did it, there's no statistical difference between the points anyway. So you can't improve on GAT and agree with GAT at the same time. And they were striving to agree with GAT. They did not want it to disagree with GAT because they feel that GAT's the thing they've got to compare to. So if you're going to have an improvement on GAT, one could argue it should differ from GAT. Well, it doesn't. So if by compensating for biomechanical errors, the IOP measurement is improved, then the two measures should really not agree. And if they do agree, then there's frankly no point spending like £6,000 or £7,000 or £8,000 on a machine that doesn't differ from GAT. That's my opinion. Luce and Taylor will have a different argument, but and the other thing is pachymetry and repeatability. We're told to repeat everything. We have to repeat GAT, we have to repeat NCT readings, we have to repeat fields before we refer. We're told to repeat everything, and yet we take a single pachymetry reading. And this particular set of authors did report on this. They said a standard practice is to take a single pachymetry reading, but they did readings and they found that there was a huge range, and I did it as well. I did repeatability of an ultrasound pachymeter, and the range was plus or minus like 18 microns. So it was huge. And I do think that really the best pachymeters would be things like OCT that do it optically. I think they're far more accurate. So, there we are. We're trying to correct for this pachymetry. We're trying to correct for CCT. And yes, there's variability in it, but then there's variability in the way we measure it as well. So it's yet another layer of confusion to the whole CCT and IOP measurement techniques that we have available to us at the moment. So there are other tonometers around. And these two, the tonopen and the DCT, do have real importance in my opinion. The tonopen came out around about the same time as GAT, but it was designed by people with a background in biomedical engineering and mathematics, not optometrists. And it's a really clever design. The tonopen is difficult to use though, and I think there's a load of error in it for other reasons. But basically its footprint is about the same as GAT. But the sensor that actually measures pressure is only about 1 millimeter in the middle. So all the bending and shearing forces and tear forces are neutralized by the non-sensitive base plate. So the tears are squeezed out, the stress forces on the bend are way away, and then it's only this central 1 millimeter sensor that records pressure, I have to say, rather than force. And the DCT is simply a 21st century upgrade on this, really. And once shell stress is neutralized by the DCT casing, the Newton's third law holds, and only intraocular pressure is transmitted to the sensor. And the DCT also, again, back to what we said about an upgrade on technology, its precision's enhanced due to gathering 100 IOP readings per second over 5 to 8 seconds. So, if there's an upgrade on GAT, you'd have to say this is little baby. And importantly, DCT is not trying to be GAT. It's, NCTs are trying to be GAT. Consequently, when they developed this thing, they didn't compare it to GAT. They calibrated against manometry. And they did not compare to the standard. And it does read higher, 2 to 3 millimeters higher than GAT. So there are other machines. There's the iCare, and it was a good design as well. Basically, its design mandate was was really a research tool rather than a commercial tool. And they wanted to measure IOP in mice and rats when developing glaucomatous models. And it records the deceleration and rebound movement of a probe as it contacts the eye. So it's different, and I think its reason for development is phenomenal. Then there's this thing that we've already said about triggerfish. And it's based on another biomechanical concept. Nothing like GAT. Intraocular fluid, you've got to appreciate, is incompressible. So any rise in IOP has to cause the shell to expand. The biomechanical expectation that corneal curvature will vary in response to intracameral IOP is real and has been incorporated into this. So it has a microfabricated platinum titanium strain gauge. So the DCT uses Pascal's law of hydrostatic pressure. This uses an equally valid concept of the shell changes. So it quantifies variation in corneal curvature induced by the intracameral IOP. It's very, very subtle though, and it does not record IOP at all. Its output is in millivolts, and the readout cannot be equated to specific measures of pressure in either pascals or millimeters of mercury. Now, the one being developed by Professor El Sheikh is trying to give a readout that means something to us, because if we got this load of OK over a 24-hour period, what are we going to do with it? Again, it's that avalanche of data that we're not going to be able to necessarily comprehend immediately. But it's a brilliant idea. So which tonometer? The DCT is based on a real law. A law you can pick up any physics book and you can read about it. It's the physical law of hydrostatic pressure. And it is the least affected, in theory at least, and I reckon in practice, it's the least affected by biomechanics because it neutralizes them, as we've showed you. But it does measure higher than GAT. But it does correlate very, very well with manometry. GAT and its GAT mimics, all NCTs are GAT mimics. They're trying to recreate a applanation process with an air plume. Its principle of operation is the Imbert-Fick and Goldman biomechanical model. This is not a law. It's definitely not a law, right? And as proof of this, it's only affirmatively cited as a law in optometry and ophthalmology textbooks and patents for ophthalmological instruments. You cannot open up a physical book, a physics book, and find a law on Imbert-Fick because it doesn't actually exist. It is an extremely simple biomechanical model, and certainly for 1885 and 1888 it was a very good starting point. But it is certainly extremely prone to corneal biomechanics, shear forces, Young's modulus and shape, and GAT specifically. The tears create an artifact that is really not part of the GAT equation. The tear error when they're too thick or too thin is really, really high. And then there's eye care, which uses Newton's third law, deceleration of a probe. And then triggerfish uses the idea that expansion of an biomechanical shell by incompressible intraocular fluid. So they're all the different principles. The one to me that's most robust is definitely the DCT. So moving on finally, that's taken like 55 minutes or something just to get through tonometry. Now back to my anatomical sieve idea. We do need to start systematically and work through the eye. So you start at the front and move in. There's lots and lots of medical sieves, but an anatomical sieve just gives you a kind of a way of proceeding through. So we've done tonometry first, then we're looking at the cornea really, and we're looking at the front. So, and first of all, you can just look at the person without a slit lamp. And you can see that one at the front, even though it's a straight on shot, you can tell that that is a convex type corneal shape. The angle is probably going to be relatively narrow. And obviously you've taken a good case history, so you already know that this person's hyperopic, perhaps +8. So again, you know that this is going to be a narrow angle. And do the eyes look okay? Do they look comfortable? Is there hyperemia? What's the iris configuration like? Then we start moving in with the slit lamp. And we start at the front and move in. So again, we have a closer look at the conjunctiva, hyperemia, neovasc. Is there any signs of trabecular blebs? Is the cornea clear? Is it edematous? And we have a quick look at the Van Herrick's. Even if you don't grade it, I mean, often I'll just go in there and say, oh my goodness, it's huge. I'll just write down 4+. And the tear quality sometimes is important, because if you're going to do GAT, you need to know the tear quality is going to be like, because you might need to augment it with fluid just to get an accurate reading, because tears is just such a blighter with GAT. So Van Herrick's is so quick and easy, and so already you've learned a lot. You've never looked at this yet, but you've already learned a lot. Okay, well, you can read about Van Herrick's, the way we measure it. I think we all know it. But basically, it grades from 0 being closed to 4 being wide open. And incidentally, grade 3 and 4, if you've graded them accurately, are technically not closable. 2 and 1 can be closable, but 3 and 4 are not. So then we move in a little bit closer, and we look at the posterior corneal deposits. Vertical thing, is it a PDS? There might be old deposits we need to know about. That might lead us to think more about what's gone on in this patient's past. Cells and flare, the iris configuration, again, transillumination, atrophy, neovascularization, synechia, and previous iridotomies or iridectomies. Then we move a little bit deeper again with dilation. You look at the anterior lens surface. PDS can show some deposits on the anterior lens, but it's primarily for pseudo-exfoliation, which I would argue you cannot see if you do not dilate the pupil. And then there's just general lens inspection, any signs of phacomorphic mechanisms linked with narrow Van Herrick's, and okay, phacolytic stuff, which is unlikely anyway. But all of these investigations are important to systematically move towards the back, because they limit poor referrals because of lack of information. You think about these GAT refinement services where they're doing pressures, they're doing optic nerves, they're doing fields, and they're referring for ocular hypertension, when if they dilated the pupils, they might say that it's not ocular hypertension at all. It's a different form of glaucoma. It's a secondary thing that requires referral in a different format. And also it directs towards further assessments such as gonioscopy or OCT. But once we've done all that, then we move to the posterior eye and the discs. So whether you consider yourself case finders or diagnosticians, I certainly consider myself a diagnostician in the community. It's theoretically our role to detect the earliest evidence of glaucomatous optic neuropathy. So the goal is to refer on an intent to treat basis at the earliest stage, and that's obviously tough. So we need as much evidence as possible for the jigsaw. We're all human, and clinical decisions can vary. For instance, you might refer a patient for normal tension glaucoma because you've physically seen a splinter hemorrhage. But by the time they get seen in ophthalmology, the splinter hemorrhage is gone, and they're faced with a patient with full fields and pressures of 15. And sometimes we may choose, I don't know about you, but I certainly do, we might choose not to refer ocular hypertension. If the IOP is 26 millimeters of mercury, but there's absolutely no signs of secondary or primary glaucoma, well, when you consider the variability in IOP measurements, a 1 millimeter reading difference and the patient's discharged. And so I may think, well, I'll just monitor this patient, and we'll show you later the nice guidelines on monitoring ocular hypertension that you're not treating, and we can do that in the community. And certainly we all, I think, have exercises where we've referred for glaucoma early, the patient's been bounced back only to be referred later and treated. And you think, well, were we actually wrong in the first place, or were we good at being diagnosticians? You don't know. So when we're looking at the optic nerve, we think of the CD ratio, and we all write it down. And the isn't mnemonic. And as they say, it's a guideline, it is not a rule. So first of all, the CD ratio should be the vertical CD ratio to reflect the anatomical reason of the isn't rule or isn't concept. But like IOP, there's no clear cutoff for disease healthy. So while many glaucomatous optic discs do break the rule, apparently 30 to 40 of normal discs also fail to obey this guideline. So studies indicate the isn't rule in parentheses has limited clinical value in POAG diagnosis, extremely poor sensitivity and specificity of diagnosis. And for instance, larger vertical CD ratios are more likely to be an indicator of glaucoma. So there's certainly statistically it's more likely. But if the clinical jigsaw is not complete, assessing the disc size may help. And I know we went through this a little bit in the last one. It's tougher to assess smaller discs because of the compact nature makes interpretation difficult. You know, you've got that 1.2 million ganglion cells going into a much smaller, and it's just basically a slightly congested disc. So optic disc size versus vertical CD ratio, it's a purely anatomical thing here. So anatomically, there are more retinal nerve fibers arcing in from the temporal superior and the temporal inferior retina into the optic nerve. And so that's why the superior and inferior are obviously thicker. But if the optic nerve happens to be larger, the thicker parts of the neural rim spread out more proportionally, making the visual differentiation of the isn't ratio more difficult. But make no bones about it, the number of nerve fibers remain unchanged. Now, Garraway Heath in 1998 decided to study this a little bit, and he found that statistically speaking, for instance, if you had a small disc of 1.2 millimeters, so long as the CD ratio was less than or equal to 0.5, you had a 95% confidence that that was normal. But equally, if you measured a 2.2 millimeter, so long as the CD ratio was less than 0.8, it was 95% confident of normality. Now that's an academic process. I doubt very much anyone's going to look in the eye and start thinking about that ratio. As I'll come on to later, I think the neural rim is a far more important animal to look at than just thinking about this ratio. But, you know, he did the study and it's true. So things that are, in my opinion, more important than the CD ratio. It is critical to assess the neural rim. And okay, we've got scanning laser ophthalmoscopes, we've got OCTs that will give us a much more in-depth consideration of the retinal nerve fiber layer and so on. But like field interpretation, these results must be viewed in the context of the overall clinical picture. You know, if the angle of the image is slightly off, it can show you erroneous results. And so you might look at one of those, but everything else is absolutely fine. You think, well, I'm going to ignore that. It has to be part of the jigsaw. It's not an all-singing, all-dancing machine that'll do away with everything else. So while the site of insult is the optic nerve head and the lamina crimosa, remember what we've always said, glaucoma is the death of retinal ganglion cells. So since the cup is simply glial tissue, supporting tissue, it seems more logical to think of the neural rim getting thinner as it atrophies, rather than the cup becoming bigger. Cup visibility, to me anyway, is a consequence of neural rim thinning. So these are the things that I think are critical. And it doesn't matter what a CD ratio is. You know, if it's 0.8 and you've got a 2.5 millimeter wide disc, okay, statistically, the Garraway and Heath thing says that they're probably normal. But splinter hemorrhages, as we've said before, non-glaucomatous patients, 0.2%. POAG patients, 4%. Normal tension-globe, 40%. So, you know, it's a pretty strong indicator. Barring of the circumlinear vessel, I think is very, very good. You'll watch the circumlinear vessel. Not all nerves have these, but you know, you watch it and it'll follow the inner rim of the neural rim. But and it's an excellent marker of change. So if the neural rim starts thinning, the circumlinear vessel stays where it is, and effectively the neural rim recedes away from it. So if you look at that image at the bottom, there's a barring, there's an area of exposure between the neural rim and the inferior circumlinear vessel. So having photographic evidence of this, so if you had, well, this patient down the bottom had suspect normal tension glaucoma, and we took those images over many, many years and they never changed. So it's a great marker for that. Focal neural rim notching is really important. And obviously in the example there, in the middle there, that example, it should correspond then to a superior arcuate loss. So therefore you've got an inferior neural rim notch coupled with a superior arcuate loss, bang, you know, that's a really good referral. Bayoneting of the vessels as the neural rim is excavated and shelved, and you'll see it coming in one out, popping out somewhere else. And then as the neural rim does thin away, the vessels just tend to be displaced nasally, which by then I think the glaucoma is pretty advanced anyway. So I think they're far more important, I would suggest, than actually thinking about just CD ratios. So then we've got the concepts of retinal nerve fiber layer loss, and we've always been able to view that very carefully ourselves, but it's much better with OCTs. So you're doing that map around the optic nerve head, measuring the thickness of the retinal nerve fiber layer, and it will show you if there's statistically thinning of that layer. And it's a very powerful test, I think, again, to support other things. Peripapillary atrophy, we've got the alpha and beta zones. The beta zone is the one that's actually adjacent to the disc, and you're looking at basically visible sclera. The alpha zone is further out. It's apparent thinning of the chorioretinal tissue and a relative scotoma. The beta zone, though, is the one. It's less common in normal eyes. It's a subtle one. I don't think I would ever refer based on that alone, but it's another piece of evidence you might put in saying, yes, we've got this, and there's a beta zone expansion. But you've got to always remember, tilde discs will have peripapillary atrophy. And incidentally, just as another side, universally, the peripapillary atrophy will be on the lower side of the tilt. So if you've got a little bit of peripapillary atrophy in one side like that, you could argue you have got a tilde disc. It might be subtle, but you've got a tilde disc. And then, of course, there's myopic crescents as well. So, peripapillary atrophy is just a very subtle sign to add evidence, not as a diagnostic test, really. So, fields, the functional outcome, and the way of monitoring progression. And there's two. I'm going to pose two debates here. So some people say, huge advantages in imaging technologies allow objective assessments of structural glaucomatous damage. But fields are still important. And we know that, we have to do them still. But we're clinicians. Now, this came from a hospital in my area. They did a lecture for optometrists, and very largely it was because they were getting a lot of false referrals, basically people doing pre-screening tests, finding a field loss, referring onto the hospital, and really causing some trouble. And as the the lecturer, the ophthalmologist said, visual fields are not harmless. You know, we put patients through these tests, possibly needlessly, and you know, patients do not like field screening. It creates, as this ophthalmologist says, anxiety for the patient. And you know, I'll have patients who would pay me money not to do it. They're often unnecessary investigations, and I'll come on to that later. They can show up incidental findings on scans which are not necessarily meaningful, and there's a huge cost to the NHS. So the NHS, this was the hospital eye service was coming at this from their point of view, and I agree with it. I think it's good. So they're saying to you, ask yourself before considering a visual field, why are you doing it? Is there a disc anomaly that you're investigating? This is why this has to be the last thing you do. Pre-screening for this is just silly to me. What are you looking for? Is it glaucoma? Is it neurological? You've got to be able to recognize unreliable fields. And is the patient actually physically able to do it? Taking into account age, visual acuity, is it 6/18 or better, and cognitive function. And this is my point, this is my statement. I love this statement. I penned it myself. Technicians measure things, clinicians do what's important. And if we're a clinician, we decide what tests we do. We don't just measure everything and then hope for the best. That's a technician's job. So a clinician should choose a test to reflect the clinical suspicions. So if you're suspicious of glaucoma, you might do a 32. If you've perhaps had a stroke, the patient's had a stroke, then you might be looking for estimate or even confrontation. 10-2 for macular sensitivities or indeed advanced glaucoma and neurological fields. And if the IOP is normal and the optic nerve has a healthy appearance, then why would you put the patient through a stressful experience? But if you suspect a problem, you need the best strategy to investigate it. That is not screening tests. You need to do a thresholding test if you're a clinician and you're truly trying to find something else. You're not screening for something. You're trying to look for something specific. And again, to bang my drum, that pre-screening stuff is just silly. Now, you know, you can have different arguments on this. You can say, well, it doesn't hurt to do a field. Well, the hospital eye service would suggest that it is. But, you know, you've got to think about this. But I do think as clinicians, we need to be taking this, and we certainly don't need to be doing it first. So certainly the mainstay of visual field examination, I say mainstay, not gold standard, remains the Zeiss visual field analyzer using either a 24-2 or a 32 thresholding strategy. I believe this could reflect historical familiarity in logistics. I have a Humphreys in my practice simply to match with the hospital service, but I also have a Medmont which has equivalent global indices, and I have listened to Professor Henson talk before, and I suspect his instruments are phenomenal. But like GATT, it's difficult to overturn the costs and inconvenience of historical precedents. Now, you know, even, well, NICE will say this. They'll say that in the case finding situation where community optometry, where the majority of patients are normal, they're saying that a super threshold testing is adequate. Now, I'm afraid I simply don't agree with that. I certainly don't agree with it at the IP level. Because if threshold tests are necessary in the co-management care, then they should be necessary for us. Now, they're saying that because the majority of patients are normal, but if you've done all that first stuff, that early stuff, you've worked your way through the eye, you're at the optic nerve, and you are suspicious. Therefore, you are no longer looking at someone who's probably normal. You're looking at someone who's probably abnormal. And therefore, that whole argument about super threshold testing is no longer appropriate. We are not screeners, we are diagnosticians, and we pick the test to suit it. So I will never use anything but some form of threshold testing. So, and even if there isn't even a defect, you know, so if you've got ocular hypertension or if you've got a family history, thresholding gives you a baseline for future comparison. rather than just comparing to an age normal. So again, another argument. Now, maybe not for patients who don't have anything else, but if there's anything that you might think, well, in the future, we may want a comparison here, then the thresholding plots allow us to see a deepening of scotomas and broadening of scotomas. So to me, for both detection and monitoring, thresholding is best. I just don't do anything else. 32 gives more information, but importantly, 24/2 and 32 results can be compared statistically. So you don't have to worry about that. If you have a 24/2 and someone else has a 32 test, they can be compared. So I take next everything out of this guy, Anderson, automated static perimetry. Whenever I learn things like this, I actually take the book and I synopsize it. And it helps me learn. And if you want to look at the synopsized version of this particular book, you can go onto my website and have a look at it. But certainly they say apostilbs are not equal to decibels. Apostilbs are an absolute measure of light, and not all machines have the same standard level. Decibels are the attenuation of light from the maximum level. But the actual amount of light depends on the starting level, and machines vary. So considering the optical pathway, we're considering 3 zones when we're considering glaucoma. They're all pre-chiasmal. So we're looking at pre-retinal, and this confounds us every day, things like cataracts and so on. These are not true scotomas, of course, but they mask other things, so pre-retinal zone is very, very important. Then there's the outer retina and choroid, that's territory 1. And in this case, the defect corresponds to the area of damage, hence there is no necessarily a pattern. They won't necessarily respect the horizontal or vertical meridians, and actually, quite frankly, you should be able to see them because they're in the retina. Then there's the retinal nerve fiber layer and optic nerve, that's territory 2, and they could be typically central or centrocecal, paracentral arcuate, and they will respect the horizontal meridian, and wedge-shaped ones will point towards the blind spot. So they may occur in one or both eyes. If the defect is monocular, it must be prechiasmal. If there's no retinal or media problems, a uniocular defect must be optic nerve lesion. And if the lesion is in the optic nerve or retinal nerve fiber layer, there may be a nasal step. But if there is a nasal step, the lesion must be, again, prechiasmal. And prechiasmal lesions associated with reduced VA, RAPD, and perhaps abnormal colour vision. So territory 2 of the visual field, again, think about the anatomy. So field losses aren't always necessarily perfectly arcuate. You can have a wedge shaped with the apex at the optic nerve. You can have centrocecal, but certainly there's the classic arcuate again because it's well, I'll come on to that. And then you can have the nasal step. Now again, the bottom left corner there shows the cross section through, and the more peripheral ganglion cells are the deepest, hence the nasal step. So for instance, you could have a lesion at the optic nerve here, and you'll have a field loss way the heck out there. So peripheral fibers are the deepest and covered by more proximal nerve fibers. And that, to me, makes them more susceptible to damage in the optic nerve. Hence, a nasal step corresponds because it's a deep, deep ganglion cell that's much deeper as it turns into the optic nerve. So, just a cautionary note, sometimes axonal death can actually be diffuse with glaucoma, leading to widespread decrease in sensitivity throughout the retina, which could mimic a pre-retinal problem like a cataract. But generally speaking, it may start uniformly but eventually unevenness will develop. So as a rule, some region is more strikingly involved than others, and the field strategies have ways of trying to detect those things to differentiate them from a generalized loss. So when we're looking at a single field, we're going to look at our reliability indices first, fixation losses. Now, fixation losses can be high and you can still have a reliable field, especially if the other indicators show reliability. False negative, false positive, short-term fluctuation, if they're all small, then you probably have a reliable field anyway, because the point could be just on the edge of a disc, and sometimes it's seen, sometimes it's not. False positive, on the other hand, are absolutely devastating. They create white scotomas. Everything's wrong. They're really difficult to interpret. And even when you do a general height adjustment, it shows relative defects simply because of inconsistent response. Fixation losses will be high, but not because they're losing fixation, just because they're pushing the button. False negatives, not quite so bad, but they certainly may appear abnormal as stimuli that are seen are not responded to. So grayscales, we too tend to look at them, but they're rather misleading. Grayscales, the thing is, it's divided into 5 decibel steps. So side-by-side points might show 1 degree of difference, but they might only be 1 decibel apart or 9 decibels apart. So the grayscale is just raw data, and it's really unhelpful. And if you think that with glaucomatous visual field defects, they don't come fully formed, so they have to start somewhere. That can be very, very subtle. So these 5 decibel steps aren't all that helpful. Probability maps and global indices are far more important. So further down the sheet, we have total deviation and pattern deviation. So the total deviation is the deviation from the age normal. As a general rule of thumb, if it's 5 decibels lower than the age normal value, then it's statistically more likely to be abnormal. You don't have to remember that. It'll give you a feed out in the bottom right hand corner. The pattern deviation from normal is the deviation of the expected value after adjustment from the general height of the hill of vision. And this is really clever stuff. So to identify a pattern possibly masked by general depression like cataract, the hill of vision is lowered and patterns may be evident. So if you look down there, we've got a total deviation there, which looks quite extensive. But then once the hill of vision's been lowered for that particular patient, then the more obvious pattern deviation becomes apparent. And indeed, for super sensitive observers that are better than the average normal, they will heighten the hill of vision. So what it does, it takes representative points of the least diseased part of the field, and it makes an adjustment to the rest of the field depending on that. So in this case, if there's no cataract, the total deviation should mirror the pattern deviation, because there's nothing in the pre-retinal area causing degradation of the overall field. So global indices, it's a statistical analysis that's striving to reduce the whole thing to a single number, and it's very good. We have mean defect, pattern standard deviation, and visual field index. So the mean deviation is derived from the total deviation and signifies an overall severity of field loss in decibels. But you've got to remember, it's an overall thing. It's not showing pattern. So a figure of -4 could mean a reduction of 4 decibels over the entire field, or 8 decibels across half the field. So it has no indication of pattern loss. A negative number is sensitive below average, a positive number sensitive above. Pattern standard deviation is whether points are different to each other. So it's an index of localized changes in the field. So a PSD will be small in a normal field, obviously, but also in a field that is uniformly depressed. So if it's cataract, only nuclear sclerotic, then the PSD will actually be small as well, which is okay, you know, because we're looking for glaucoma here. But PSD becomes larger as some points are more effective than others. So percentile probabilities are given when it exceeds 90% of normal fields. And then we've got this visual field index where 0 is blind, right, basically. I don't think I use that very much. So if you do the 32, it takes longer, but it actually gives you more information. It gives you a short-term fluctuation, SF, which leads to what we call the corrected pattern standard deviation, CPSD. So short-term fluctuation first is the measure of repeatability of the threshold at a few retest points. That's why it takes longer. So it's back to these points and it retests them. So it's high in inconsistent responses. So because you test the same points, you get different results. So hence it is a reliability index. But also diseased retinas have an abnormal index as well. So it's really needed to make a correction for pattern standard deviation. But so, with this, you've got to look at the overall picture. Does it fit in with what you're expecting? Is the short-term fluctuation that you're reading a reliability index because you don't trust the field? Or is it there because you're already very suspicious that there's a glaucomatous loss anyway, and that's why it's there? But its main reason, I said, is to correct for this. So we corrected pattern standard deviation. This is the pattern standard deviation corrected for the short-term fluctuation. So it's a more accurate index of the difference between adjacent points. So basically, it's a CPSD is equal to the PSD minus SF. And it can be lower than the PSD if the SF is really high. Cling to that point anyway. But it's this correction anyway. And then we got the glaucoma hemifield tests. So remember, the damage to the superior and inferior, it might occur in both, but it's not going to be equal. It's extraordinarily unlikely that the two hemifields would be, at least in the early stages anyway, affected at the same rate. So it's very important to compare corresponding regions of the upper and lower hemifields, and asymmetry is often striking when comparing a cluster of points above and below the horizontal. And it again will be flagged as within or outside or borderline of normal limits. So it's a very, very good test for glaucoma. Obviously, it's targeting glaucoma. So at the end of a field, everything should really tie together. And you have to think about how they all dovetail. A high false negative coupled with a high short-term fluctuation, they are expected in truly abnormal fields, but also as artifacts. So a diseased retina will have low sensitivity, but a fatigued retina will have abnormal points leading to less sensitivity and more apparent false negatives. So knowledge of the clinical setting helps. If the IOP is elevated, again, back to what I was originally saying, we're clinicians, we're looking at it, we're tying it all together. It's got to tie together. Is IOP elevated? Does the disc appearance look abnormal? True defects may be unequal between each eye, whereas a poor observer will be equally unreliable in both eyes. A normal field, well, we've got to try to differentiate between a normal field with false negatives or an abnormal field with false negatives as a feature. So true defects may be accurate, pseudo defects tend to be random. So you've got to tie it all together. Is the defect that you see characteristic of the disease in question? So again, we're not screeners, we're not doing this as a pre-test, we're doing a targeted thing for a particular disease that we're looking for. So up till now, that's taken an hour and a half. That's been pretty grueling. What I'm going to do is, the next phase is to discuss quickly about gonioscopy. But what I'm going to do is, I'm going to stop here and I'm going to cut this out and do it as a separate mini chat of probably not more than about 15 minutes. So thank you for listening to all of that. All good fun, and we'll get on to gonioscopy in a moment.